I work in Barcelona in a transcultural psychiatry program. I've been there for quite a few years, doing clinical work, research, and a lot of training. And as I'll tell you in a few moments, work on issues related to intercultural mediation. But the title of this is Cross-Cultural Understanding of Health Needs, Cultural Mediation. So there's a few little bits to it. Initially, I was only focusing on cultural mediation, but then after Aliki's presentation yesterday, I was like, oh, I better talk about the cultural bit. So I will do that. And this is sort of the agenda. They're going to kind of be three parts: the cultural bit, the need bit, and the intercultural mediation bit, right? And in there, we'll say, what does culture matter and what is understanding? But first, most of the presentations here are done by epidemiologists. You take a very serious scientific kind of a viewpoint. I'm one of those fluffy, qualitative psychology types, where we take a sort of a more bottom-up kind of perspective. And in that respect, I acknowledge I have my particular orientation as being somebody born and reared in the West. For the most part, my father was from India, which confuses things a bit. And I was trained in the United States in multicultural counseling. So that's going to very much inform the way I'm speaking and represent certain perspectival limitations. And certainly a bunch of prejudices that come into play, and these are just some of those. We're not just talking about culture, we're also talking about power imbalances, particularly what could be called socio-race. And one of the dangers that we certainly feel, or some of us feel, is that of exporting, imposing our particular models onto the rest of the world, somewhat along the lines, I think, of the question that Nabil asked earlier. And these are a couple of excellent, one is a book, one is an article that really do a very nice job. The one by Moghadam, he's an Irani psychologist, and super interesting about how we interpose different models on top of each other. So, just a reminder, we are all cultural beings. One of the dangers that sometimes happen is we talk as if those refugees are cultural, and we're not. We often forget the degree to which culture is impacting everything that we do. And so some cross-cultural psychologists said something about it's like water. We're not even aware of how profoundly culture impacts us. And certainly, for myself, as epidemiologists, we have a particular culture that we're operating on that we may not always be aware of. Now, culture is a horrendously complex construct, to the extent that once upon a time in the late 90s, anthropologists were saying we should get rid of this construct because it's just too all over the place. But nevertheless, it's what we have, and we can talk about 4 X's: experience, expression, explanation, expectations. And you've probably all seen this annoying iceberg. But what I think is helpful about the iceberg is just to sort of remember that so much of culture is impacting us in a manner that is invisible to us, both for ourselves and for other people. And hopefully I'll be able to illustrate that in a few moments. Now, more and more, I've got to be closer. Oh my God, I didn't want to be too loud. Sorry. As we know, more and more, nature is nurture, or nurture is nature. They're inseparable. It doesn't make any sense to talk about one without the other, because really, those of you who have had or have babies, when they're born, they're not really human, right? It takes a few years of nurturing for them to become real people. And if they don't have that human interaction, they become very strange creatures, which sometimes, sadly, we find out. And so they have interaction with parents from the very beginning or from their caregivers. That's culture right there. Culture is growing. And so nowadays, increasingly, there's this area of the cultural neurosciences saying, wow, our wiring is cultural, so to speak. And that's very profound. And I'll try to just illustrate that. This is an article I came across last year, and I think it's really, really interesting. You're probably all vaguely familiar with attachment theory. This is about the kind of bond that develops between caregiver and child. The research, of course, has been done in the West, and it's been predicated on the kind of model that you see on the top 2 pictures, a combination of direct face-to-face interaction with an infant, with a great deal of intensity and exclusivity, and then we put the baby down, we put them in their playpen, and then we go about our business, and then we come back to the baby and go, ooh, goo, 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 how's my baby, da, da, da. Right, we're doing all that kind of thing, as opposed to what we see in other parts of the world, which is more of a network, a parallel network, where you can reach out and you'll always be touching somebody. You won't be necessarily getting a lot of face-to-face attention, but you're always touching somebody. There's always that kind of security. It's a rather different kind of a model. The upshot of that is that we have a Western kind of a self, which is all about individual uniqueness and enhancement. And that's what we focus on. What do you like? How are you? And then it's about how I feel and what I want, and it's all this I talk. As opposed to what we see in these more collectivistic cultures, which is fitting in to a particular hierarchical order and fulfilling particular roles. What you want or what you like doesn't matter, because that's not who you are. Who you are is where you fit in. My father used to tell me about some friend of his who I don't know, maybe saw me when I was a baby, and he'd say, this friend loves you very much. I was like, how can somebody love me? They don't know me. Well, they don't need to know me. They need to know that I'm my father's son and I'm fulfilling a certain role, and that's sufficient. And to me, this is a wonderful illustration of the potency of culture at a very profound and basic level that influences then how we interact, how we engage, and how we talk to each other. And certainly as a psychotherapist, talking with patients, and I think Aliki also kind of brought this up, right, where a patient says, yeah, why are we talking about like how I feel? That's really irrelevant. It has no bearing on anything. Now, what, right? And so it's inviting us to shift some of our perspectives. This is one model of cultural dimensions. There are many models of cultural dimensions, and they certainly have their problems, but they're also interesting to help underscore the degree to which we are deeply embedded well, I think most people in Europe and North America, et cetera, are embedded in these red circles or ovals, for the most part. And that then influences the way we structure medical care, it influences the way we interact with patients. The whole thing is assuming a certain sort of self. And of course the error is, well, not all selves are like that. Now, certainly, I put emotion in yellow because we have a great deal of variability on what emotion is like, which I think we'll come to in a second in another slide. And certainly I've circled schedule because we certainly, at least in standard consultations, we expect patients to show up on time, and when they don't, it's all sorts of problems. Well, so this just sort of speaks to some of the ways in which we are embedded in our culture as at a fundamental level of experience. And we can talk about how we express ourselves. Obviously, language is fundamental, but then there's all the nonverbal communication, the emotional expression. How much is an appropriate amount of expression, emotion to express? As we were talking yesterday, our friend from Sweden, right? How much emotion, to use a stereotype, do Swedes show, and how much emotion do, say, anyone from the Mediterranean basin show? It's just very, very different. How do we express pain? Is it going to be a very stoic, yes, it hurts and your leg is broken? Or are you going to be, my leg is hurting me? Right? It's not better or worse, it's just very different. And that's our challenge, because it's speaking so profoundly that we make the interpretation of the other one saying, oh, this person is so cold, oh, this person is so emotionally unstable, because we're using our own particular register to make that interpretation, and that's the danger. And then there are a few more elements that we can look at, right? And in all of them, they're phrased in such a way that betray a particular cultural bias about what is normal, how loudly, et cetera, et cetera. These are biases. And in other cultures that are very indirect, for example, well, we know how to read between the lines. My mother used to drive well, you know, if you have somebody from a culture in which we expect people to read between the lines, they just expect you know what I mean, because what I said was this, but you have to read all of the other contextual information. For those of us coming from places like Canada, we just hear the message, we just hear the words, and this can give rise to considerable problems. And then we get to the explanations. This is something that then says, what is the ideology, the ways in which we put together explanations for what's going on. Now, this comes from a book, a very interesting book. It happens to be about depression, but I think it could probably be about a whole lot of other topics, which is, where do we put the focus, right? As opposed to something like holistic medicine, which goes in contrast to the Cartesian mind-body dualism. But this is, in fact, insufficient, because it stops at a certain place. we might want to go and include the spirit, but we also might, if we were to consider at least, say, Native American cultures, consider the ecosystem, that the environment is also part of a person. It's not something separate, which is something that I wouldn't even have thought of if somebody hadn't mentioned it the other day. But then we think, okay, how are we managing our treatment? And I think that's something that we're all kind of contemplating as we think about the horrendous situation in which a lot of people find themselves. Because the point of focus might want to be at society and culture, but obviously, so far it doesn't seem like anyone has figured out how we can change society, right? We haven't got that down yet. That's for later on today. But it does sort of speak to where we're focusing our energies and on what basis. And what do we do with those patients for whom the spirit world is something that is live and real? And is that even something that we'll take into our consideration as we're engaging with them? Or will we see that as some culturally cute way in which they operate, unlike our accurate biomedical perspective? And finally, we can talk about expectations. What does a person expect about the distress or their illness, the course, the outcome? How should it move along? When do you seek help? When do you not seek help? When do you take medication? Do you only take medication when you're symptomatic and then stop because you're no longer symptomatic? And what kind of relationship are we supposed to have with our healthcare professionals? And how should we treat each other, and so on? So all of this is, culture is informing this and impacting us, and oftentimes we get it wrong without realizing it. And then we make attributions to the patient on the basis of these errors, and we respond to them in this somewhat problematic kind of a way. Now, in an ideal world, of course, we'd all be culturally competent. It would be really easy. Now, you might say, what is cultural competence? And I can't answer that right now. But basically, we could be completely responsive to our patients, taking everything into consideration without allowing that to get in the way. And I don't know if anyone here is familiar with these concepts like absolutism or imposed edict. This again comes from cross-cultural psychology, and the danger is that we assume that we get how the world is, how human beings are, and we simply impose this model on other people, and we say, this is right. And so when a patient comes in and they start talking about being possessed, we say, well, that's cute, that's a cultural explanation, I get it, but what's really going on is you have problems with your neurons or something to that effect. Well, then what we're doing is we're imposing our particular worldview on the patient. And are we right? Well, that's a whole other conversation. But we have to be very careful about not succumbing to pig-headed ethnocentrism. This comes from the philosopher Richard Rorty, and ethnocentrism is to say we all see the world from our own particular perspective. That's a given. We can't get out of ourselves. What we need to do is try to be benignly ethnocentric, understand that we do that imposition, and we can certainly see common humanity in all people, but understanding that we have very different ways of dealing with certain central aspects of our existence. But sometimes we might even want to go to relativism or emic approach. I wrote edict, I should say emic, which is to say from the ground up, from the perspective from the inside. And that's really, really hard to do. But that's what we need to be able to negotiate if we're really going to contemplate culture. Now, these things are really hard to do, so we can look to intercultural mediation, because intercultural mediators can really help us with this. And here's a definition: professionalized bridging of the linguistic and cultural gap in communication and the facilitation of the therapeutic relationship between health professionals and service users. So there's a definition, right? And it's really about compensating for the lack of cultural competence at an individual and institutional level on the part of the various entities and people that are applying things. But of course, a lot of you are saying, no, that's not what intercultural mediation is, and you're probably right, because there's a lot of different definitions depending on where you go and in what context you're operating, and sometimes within the same city or country, you have multiple different definitions meaning multiple different things. For our perspective, the most important basic element is our capacity to communicate with our patients. And then we have other kinds of roles that might come into play. But one of the dangers, of course, is telling the community health agent, go do X behavior, which really should be done by a nurse or a doctor or somebody who's specifically trained to do that. Sometimes we run into this danger of saying, well, because they're not like us, will use a lower quality of care for them, something that we wouldn't do with us, however we want to define us. So the model here comes from all these different sources. Certainly in Belgium, Antoine Gailly, he was a psychologist, and he was involved in the development of the program they currently have in cultural mediation. He certainly taught me a lot about the role through a number of different experiences. And there's also the idea of cultural humility, which is to say we really need to recognize our limitations and the great danger in thinking that we get what's going on with somebody from another culture. Certainly, as we all have no doubt have had experiences in which we're communicating with our spouses or whomever, and we have these huge misunderstandings and huge fights, this person being from the same culture. So we need to know what our limitations are. And then we've had a lot of experience working with training mediators, starting in 2003, and doing vocational re-entry workshops. And then for 2 years, we had the opportunity to work with our Department of Health in Catalonia and La Caixa Banking Foundation, a huge number of mediators and a lot of hours of training. Anyway, okay, so I'll get to what is a cultural mediator. They are somebody who provides linguistic and cultural interpretation. They contextualize culture. They cannot be experts on culture, but they can contextualize culture. They can provide information about how the healthcare system works, and they can normalize difference. That is to say, here we have a person who is simultaneously part of the healthcare system, but also a representative of the community from which the patient is. Now, they shouldn't be an expert on the culture in question, and we could debate that at length, but I think the whole notion of being a cultural expert is highly problematic. I don't think it makes any sense, because what is the culture, what is the limitation, what is the so on. Again, you think of, we have our patients, we have people from India and Pakistan in Barcelona, and we say, oh, this is what Indians and Pakistanis are like, and I'm like, well, my father was never like that. So we have to be careful. They're not a solution to the immigrant refugee problem, which sometimes happens. We just sort of go, oh, you take care of that person because they're from your country. They're not there to cover deficiencies of other healthcare professionals because the doctor doesn't happen to know how to or couldn't be bothered to explain a particular issue to a patient in a language that he or she can understand. That's not the mediator's job. That's the doctor's job. They're not there to explain why patients do what they do. Why does this person do that? Why do Moroccans somaticize like this? Why does anybody do what they do? That's it's a somewhat ridiculous question. Nor are they there to convince the patient to do this or that behavior. That's up to the doctor. And they're also not there to go and spend time with patients because they happen to be from the same country. We're talking about a healthcare professional. If a Canadian patient comes to my hospital in Barcelona, they're not going to send me to go talk to them because I'm Canadian. That would be ridiculous. So we can talk about some of the role issues. What do they do? The sort of traditional notion is that they do more or less what a medical interpreter does, as I sort of said. In effect, they lend their voice to the two participants. All they're doing is message conversion. And without a doubt, that's a highly complicated and problematic issue. And if we were talking about mental health care, we would say this simply doesn't work because they're a very present presence. Some of the complications that give rise. Now, what we want, ideally, is a mediator that facilitates the relationship between the service user and the clinician in this kind of a picture that we have here. Now, as sometimes happens, people don't want to have this third presence in the room with them, and we've seen a lot of reticence about having a cultural mediator present. We have a danger of alliances, and the wrong kind of alliance, with the mediator becoming the focal point. And so then the patient looks to the mediator for everything, and what is lost then is the relationship with the healthcare provider. And that really is the basis of good outcomes, is that relationship. So we need to figure out how to not have that happen, to avoid that, and there are various techniques that can be used. We can also talk about the mediator as the gatekeeper, particularly when neither of the two parties understands the language of the other. The mediator is controlling everything, and neither of the two knows what's really being said, and that can be a particularly complicated issue. But then what can also happen is what happens when you have a mediator who represents something about the patient's anti-culture or culture that they're not comfortable with. And that can then disrupt completely the whole process. So just because a person speaks Arabic doesn't necessarily mean that they're an appropriate mediator, because they may be coming from conflicting groups, and that can cause far more problems than anything else. Some more role issues. Sometimes it's not clear what the culture mediator is supposed to do, and they end up in this kind of strange thing. Am I a intercultural mediator, but I'm also this important person in the community? And then I give out my phone number, and then people are calling me at all hours of the night. Now we say, don't do that, you're a professional, but that can be tricky. Discomfort with certain issues and certain contexts. If suddenly any issue related to sexuality comes up, that can make people very, very nervous. Sometimes the mediator doesn't really understand the medical process and might start trying to tell whomever it is that they're doing something wrong when they don't really understand what the deal is. The issue of clarifications and contextualizations can also be difficult, and this can be illustrated with a metaphor. So if the patient says, I have the devil inside of me, okay, is the patient speaking metaphorically or is the patient speaking literally? Maybe they're psychotic, or maybe they're speaking metaphorically. The mediator shouldn't be the one to make that decision. So they need to be able to find a way to simultaneously say, the patient said X, and this may be a metaphor for Y. And that can be challenging. And as we see, sometimes patients are not comfortable with the mediator, and we can see examples of this kind of situation where they're not going to say something because they might feel shame in front of the mediator, particularly in the face of something like sexual violence. What we also see are because physicians and nurses and so on are of higher status, higher professional status, they may ask the mediator to do things that are simply not within the mediator's job role. I've even seen it happen that a social worker said to a mediator, well, why don't you stay with this patient's child? Basically babysit. Right. And then there's little clarity as to the place of the mediator within the healthcare system. So unless we're Belgium or a few other countries, they actually don't have any specific legal status within the healthcare system. And so in theory, they shouldn't be privy to all this stuff related to patient confidentiality. Sometimes mediators will engage in activities that are problematic. This has happened, I've had this experience with mediators. Well, they'll say to the patient, there, everything's going to be all right. Well, sometimes everything isn't going to be all right, and that's not a particularly good message to give false hope. Sometimes they will change the message. Right? They'll change the message because it makes them uncomfortable, and I'll give you an example of that in a second. They might also censor what the doctor says or what the patient says, simply because they, again, related to the previous one, they're not comfortable with what is being said. And we've even seen it happen that they end up moralizing or confounding personal feelings with cultural norms. They might have the idea, this behavior is inappropriate for a teenage girl from my culture, therefore, and they'll start intervening, because they're not maintaining their professional role. This is an example. This was from an interview with an interpreter. And as you can see here, the question was, how many sexual partners do you have? And the mediator said, well, this is a question that's completely, it's offensive. I can't ask that. And so the mediator asked the patient, does your husband go with other women? That's completely different. And of course, the poor doctor isn't going to have any idea that they've been given false information. So what do we need? Well, obviously we need training, good training for the intercultural mediator in a whole bunch of different elements, some of which we have covered, most certainly in linguistic translation, because that is one of the hardest jobs there is. When we've evaluated some of our mediators in previous years, we've seen a good number of omissions, changes, additions to the session. So there needs to be training. Certainly, medical professionals need to learn how to work effectively with mediators. And we've seen that they don't. They simply assume that they do. Hubris is problematic at times. The intercultural mediator needs to be a professional role, but that means formalized within the medical system and so on. Right? So big part of it is the mediator needs to feel like they are a professional. And if we can do that, train them so they are professionalized, that can certainly shift a lot and make their work more effective. And on that note, I will say thank you very much.